Good evening, everyone. Welcome back once again to this third episode of Applied Immunology webinar series. We have already discussed about the fundamentals of applied immunology, especially to a practicing pediatrician or a practicing allergist. And then thereafter, yesterday, we have discussed a lot in depth about different allergy conditions, their immunological process or their immunological reasons behind them. And then thereafter, we also discussed about immunotherapy and the details and the intricacies of immunotherapy and the immunological reasons or basis or rationale behind immunotherapy. Now, today we will be going a little more parallel, in which when a child is presenting to us, especially in the outpatient department, and at that time we really don't know that whether this particular child is suffering from real allergy or it is allergy mimicker. Common allergy mimickers could be some sort of immunodeficiencies, it could be some recurrent infections, and then sometimes an autoimmune phenomena can also be playing part. And sometimes this particular child requires actually certain sort of biological therapies. And so today we'll be discussing all these things, that how these important uh, differential entities needs to be suspected, needs to be discussed in different special clinical situations by our experts, and for which I would like to invite our moderator for the day, Dr. Vipul Sharma. Dr. Vipul Sharma is senior consultant at Max Hospital, Gurgaon, and he is a practicing pediatrician and an allergy specialist. So, Dr. Vipul, thank you for accepting our invitation, and you can please start now.
Okay. Good evening, my dear esteemed colleagues, faculty, and friends. First of all, I will thank Dr. Neeraj for giving me this opportunity to moderate this session. It is my privilege to welcome you all to this focus session on clinical immunology in special situations. As you know, pediatric immunology is a fascinating field because children's immune system are not miniature version of adults. They are unique, evolving, and often unpredictable. And in clinical practice, we are frequently confronted with a situation where the immune system doesn't fit into neat textbook categories. As pediatrician and allergist, when we are continuously practicing in the field of allergy, it is easy to become focused, sometimes even obsessed with the diagnosis of allergies. But this carries a risk. In doing so, we may overlook important clinical clues that point towards something else, perhaps even more sinister underlying disease. And when this happens, the right diagnosis and treatment may be delayed with potentially adverse long-term outcomes. So today we are focus on these issues also. So this session is a reminder to all of us that while allergy is common, we must always keep our clinical vision wide, alert to the possibility of immunodeficiency, autoimmunity, or other immune dysregulation that can mimic allergy. Today's session is built around four such scenarios that are both common in practice and challenging in interpretation. These topics highlight that the clinical immunology is not in pediatrics is not only about understanding immune defect, but also about applying that understanding in real world situation to diagnose it earlier, treat smarter, and ultimately improve the lives of children in their families. With that, let's begin the session. Our first topic is when allergy mimics immunodeficiency, red flags for the pediatrician. Our first speaker, Dr. Payal Malhotra, will guide us through these subtle critical clues, helping us differentiate allergy from the immune deficiency and apply practical strategy in our clinics. Dr. Payal is a consultant in pediatric hematology, oncology, and bone marrow transplant at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. She has been awarded the prestigious St. Jude Pediatric Neuro-Oncology Fellowship. She is also a teaching faculty for the NBE program. She has received several international fellowships and scholarship and has over 25 research publications to her credit. Please join me in warmly welcoming Dr. Payal Malhotra to share her expertise. Over to Dr. Payal.
Thank you so much, Dr. Vipul, for the kind introduction. And at the outset, I want to thank the organizers for this applied immunology for letting me talk on this. Actually, it's a very challenging topic. Dr. Neeraj, a special thanks to you for probably having this topic here. And let me, give a disclaimer that it is not just that pediatrician need cues that they get confused कि ये PID है या allergy है. It is actually it may be a diagnostic dilemma for a hematologist or an immunologist also. On that aspect, starting with the presentation. So I'm from Rajiv Gandhi, which is a 500 bedded standalone oncology center where we are looking at all the hematology cases, oncology cases, and doing bone marrow transplant, whether it is haplotransplant, unrelated donor transplant, or matched sibling donor transplant. I know this topic has already been taken about, what are the components of immunity and how it acts, but I'm going to use these terms very frequently in the coming case scenarios. And just a little revision for our residents here, we know that you've got innate immunity, which is a non-specific immunity, which is composed by macrophages, dendritic cell, mast cell, neutrophils, which I call the senapati of all the cells to fight infections, and then specific immunity, which comes through your T and B lymphocytes, right? Now, just to brief a little bit, whenever an antigen comes in the body, you know what happens? So there is an antigen presenting cell, which is like a scooter. Okay, I call it a scooter. The antigen will sit on that scooter and it will take it to CD4 or CD8 positive cells, depending upon which MHC class it is associated with, MHC1 or MHC2. Now, what will CD8 positive cell do? CD8 positive T cells has got these weapons, interleukins, interferons, TNF. It is going to release all that, cause a cytokine storm, and kill the antigen. What are the helper T cells going to do? CD4 positive. जब उनके पास the antigen presenting cell will take the antigen, they will activate the B cells, tell them to produce antibodies, and again cause antibody dependent cytotoxicity. Then you've got these other system, complement, phagocytes, and all of them, which are also doing their part. So we know that there are either a primary immunodeficiency or secondary. Primary, we're not going to discuss secondary HIV, chemotherapy. We're going to talk about primary, which are now actually termed as inborn error of immunity. They're no more called as primary. And let me tell you one more important thing. We are calling allergic mimickers of inborn error of immunodeficiency, but per se, PID or inborn error of immunodeficiency are really rare disorders, very, very rare. And if I were to say, I don't see them daily in the OPD, probably, one case. I mean, in the year, you can count on fingers how many cases have you seen. Probably Dr. Neeta has seen more cases. Definitely at our center, we see number of cases that we can count on the fingers. And IgA is an exception, but that also is more common in the white population, not that we see it in India. So it's a rare disease. When I say cues, you really have to think that that is the last thing that you have to think. Only if there are specific points that you have to think about. So when to suspect, we know that positive family history. Why have I put this point is very, very simple. Again, for the residents, most of the immunodeficiency are X-linked or autosomal recessive. I'm saying most of them, inverted commas. What does that tell you? That you have to have a 3 pedigree chart, right? So when you look at a patient, whatever signs I'm going to tell you, you have to make a 3 pedigree chart, because if it is X-linked, then the females are going to be carriers and men are going to be affected. If it is autosomal recessive, you have to take the history of consanguinity, right? If this autosomal recessive, both the partners will be carrying the gene, right? Then we talk of unusual sites, unusual pathogens. Again, when you say unusual sites, sometimes, for example, let me go to the next slide. So these are European Society of Immunodeficiency with warning signs that have been given, So a lot of residents will say, oh, this patient had 3 times otitis media, 4 times otitis media, or, had this particular disorder. So likely we should think of immunodeficiency. He has allergic disorder also. No, you have to see whether it is the same anatomic site which is getting infected again and again, then likely it is the defect in the anatomic site because of which there is repeated infection. So if you have an abnormal anatomic site, say a liver, a brain, or you have disseminated infection somewhere, like it happened in the lung, now it happened in the ear, then it happened somewhere else. If it is the same site which gets infected again and again, it is likely a defect in the anatomic site and not like a recurrent infection. So we'll also talk about the fact whether what is a recurrent infection and what is a frequent infection, because again, these two terms are very, very different. Pediatricians, we do have mothers who will come to us and say, ये तो बार-बार बीमार होता रहता है, ये तो पनपता ही नहीं है. So बार-बार बीमार or frequent infection again is something which has to be differentiated from the definition of recurrent infections, which has been clarified by the European Society of Immunodeficiency. Yeah, so I specified autosomal recessive and recurrent infection in the single cell. Classification, I'm not going to do this jargon again as it has already been done. You know, the defect could be anywhere: macrophages, B cells, T cells, complement, all of them, some of them, two of them. And probably what my topic is that lot of them may actually present as allergies. So to you, how many patients are there who may actually be presenting with allergies and they have got PIDs? So I had this paper which was published couple of years ago, and if you see, this was one of the largest, I would say, study, a worldwide study which was done by World Allergy Organization, where they took in account 23 countries together and they looked at 8,450 patients with inborn error of immunity. And what they saw was that nearly, on a, I would say, mean was around 16.3% of patients actually were being diagnosed or were being treated for allergies. So allergies could be atopic dermatitis, bronchial asthma, atopic dermatitis, rhinitis, food allergies, and the range was like 1% to actually 10% to 28% at different centers, depending upon whether it was a sub specialized center or it was a remote center, where they saw that some centers even 30%, 28.8% of patients were being actually treated as allergic disorders. So probably that is the importance of keeping this topic here. Again, one more study which was very recent, where it was a prospective study where they saw 385 patients who were admitted with suspected immunodeficiency. And again, most were referred to the institute as recurrent respiratory infection, atopy, autoimmunity, something like that, or a food allergy. But actually, there were cases of PID. And to be honest, we also get such referrals where they would either be referred to us as autoimmunity, atopy, or a chronic dermatitis or something like that. Coming to the case, so this is a 9-month-old male child. Okay, non-consanguineous marriage. The points I specified, I'm trying to bring them in my history. Non-consanguineous, who presented with eczema for 3 months, failure to thrive for 3 months. So this mother actually said कि ये skin ठीक नहीं हो रहा है, खुजली करता है, सोता नहीं है, and पनप नहीं रहा है, he's not growing well. When we looked at his anthropometry, he was between 5th to 10th centile. He was irritable, tachycardia, mild pallor was there. There was mild thrush, no lymph nodes as such, mild hepatosplenomegaly. And then definitely the complaint was widespread eczematous rash, and that was actually lichenified in the flexure area. Yeah, and then we could see signs of secondary infection because of recurrent itching and excoriation and all of that. Now, why did he come to RGCI? Why did he come to our hospital? It was actually atopic dermatitis with ITP. So they thought probably this child has autoimmune issue with atopic dermatitis and with ITP. So ITP Q, this child had borderline platelets. So they thought that probably there is some autoimmune issue. This was a child at Railway Hospital actually, which came to us. So when this child came to us, we tried to take a detailed history. A fellow took the detailed history and said that, ma'am, likely there is history of recurrent infections. The mother says कि जब से पैदा हुआ है तब से बीमार है. So that is the history usually they'll give. They said he had 1 or 2 episodes of discharge from here, which again doesn't bother us so much because we know ki kaan behta is something, children in this year may in age may have, but this child is 9 month old. Okay, so it's catching my attention. One episode of pneumonia which required hospital admission, impetigo, which was probably, there was another prescription which said impetigo from a skin specialist which said augmentin was given. And then history of frequent nosebleeds. They said the child gets epistaxis and mother was trying to relate it with summer season or poor feed or whatever. Then frequent diarrhea ki बार बार dust लगता है, and 2 to 3 episodes of blood in stool, for which, as per mother, the child was given albendazole, metrozole, it became better. But I have actually put them all together because they are telling a story now. Um, and initial treatment was multiple courses of antibiotics, emollients, albendazole, nasal drop. So probably what we're looking at, our resident, what he saw was there was severe atopic dermatitis because that was written on the discharge summary, with some allergic diathesis, with failure to thrive, with frequent infection or recurrent infection. Now, when we see frequent infection, what is frequent infection? If you try and look at the definitions for that, it says that if you have got more than 6 URIs in a year, some statements or some guidelines say 10 URIs, that is called frequent. Recurrent infection is something which is defined what I showed you for the PID guidelines, right? So, anyways, we investigated because this child came to us for ITP, did not come to us for skin problem. Definitely, RGCI patient won't come for skin problem. And what we saw was hemoglobin was 10.5, TLC was 7,000, DLC was okayish, platelet was 80,000, borderline low. The MPV was 5 and RDW was 14. So moderate anemia. Why do I say moderate anemia? For a 9-month-old, actually less than 10 grams becomes severe anemia. So this child had moderate anemia, thrombocytopenia, which was borderline, and a low MPV. Right? Stool routine and occult blood was also sent because mother was really bothered. Why does blood come in the stools? And we asked our pathologist, and what he told us was that they are really small platelets. These are powder-like platelets. So we're trying to join the dots. The child had um, and yes, the resident also sent a coagulation profile because epistaxis was there, and there was blood in stool. So the resident also sent PTA, PTT, and INR, which looked absolutely normal. Now, what kind of bleed it is? Likely a platelet kind of bleed. You don't have joint bleeds, right? The child is crawling, the child doesn't have joint bleeds. But platelet type of bleed with a platelet count of 80,000 is very, very uncommon, right? 80,000 pe, you're not going to have epistaxis, you're not going to have bruises. Yeah, mind you, when we saw it at RGCI, this child had couple of bruises as well. So 80,000 should not cause that, right? So there has to be a function affected, platelet function affected. Now, 9-month-old, borderline platelets, platelet function affected. Are we looking at Bernard Solier? But this is an isolation. There is another history which is recurrent infection or frequent infection. So the resident said, hey ma'am, should we send an antibody subset analysis, T cell subset analysis? Is it warranted here with one episode of otitis, some diarrheal episodes? Should we send that? And skin lesions, is it atopic dermatitis? Is it eczema? And then we're thinking about Hermansky Pudlak, which has neutropenia. So neutropenia was not there. Shedea Kakashi, they're very, very characteristic. They will have albinism and all of that. And whether this is Viscott Aldrich, which has a pentad with diarrhea, eczema, thrombocytopenia, and definitely which is PID, that is an immunodeficiency itself with recurrent infection. So were we actually looking at a classical Viscott Aldrich syndrome? What was this? So severe atopic dermatitis? No, because this child has thrombocytopenia and infections and other thing. Were we looking at primary immunodeficiency Viscott Aldrich? Yes, we thought, because the other immunodeficiencies that we thought Hermansky Pudlak or Shiria Kakashi, they did not have the characteristic phenotype. Were we looking at a platelet dysfunction disorder? No. Looking at the CBC, we did think, especially the child was 9-month-old. So first of all, a 9-month-old ITP should not have been thought. But anyways, Bernard Solier, no, because this child has the other things. So we should not think that this is because of one disorder, the other thing is because of other disorder. We try to make one diagnosis. Could this child have a combined immunodeficiency like a SCID or an Omen syndrome? SCID are usually very, very sick. They would present usually at birth or first month of age or 2 months of age. Omen syndrome, yes, because Omen syndrome may also present with diarrhea, with eczema, with the same thing. So what were we thinking? And the resident said that probably our pathologist said, hey, these are like small platelets, powder like platelets. We told him the whole history, and he said, hey, just send the NGS for Westcott Aldrich syndrome. This shouldn't be anything else. And that's what we were also thinking with all this. Anyways, we got an immunoglobulin profile. The IgG was borderline low, IgM was very, very low. I haven't written the values because remember, there is another point that I want to tell is you have to look at the immunoglobulin profile as per the age. It has to be age appropriate. When you get values from Lal lab or any other lab, they have the adult values. You have to look at the age appropriate values for this immunoglobulin profile. I've just written IgA was normal, IgE was little high, and then I have put the adult values, I'm not putting here. Then we asked our pathologist to also do a T cell subset analysis, and what we saw here was, I just wanted to show this flow plot, the flow plot that we did through the beading technique. So if you see here, what we did was that this is CD45, okay? So your lymphocytes, they are going to be like CD. So this is like CD45 cells that we have selected, right? So the more you go to the right, that much is the positivity of the cells, right? Of the CD45 cells, you have all the mononuclear cells. You've got CD4, CD8, you've got the NK cells, whole of this lot that you've got, right? So these were about 99,887 cells. Just for calculation, let's take it 1 lakh. Okay. Come to this plot. I'm so sorry. Come to this plot. You see CD3. Can you see CD3 on x-axis? So these were CD3 positive cells. We have separated the mononuclear cells and the NK cells and we've separated the B cells here. Okay. CD19 are the B cells. So we've separated B cells. These are your CD3 positive cells. If you look at this lot, okay, these are the CD8 positive cells and these are the CD4 positive cells, that is the T cells. Okay. So CD3 say we selected the T cells. Amongst the T cells, this purple plot, we tried to separate the CD4 and the CD8 positive cells. Now, just for calculation, there were about 1 lakh cells, CD4, CD8, that is your जो total cells थे उसमें से CD4 are about 16,495, which is approximately 14%, and then CD8 positive cells, which was about 12%, 11 point something percent. So they have this complex formula that they put and give us the absolute values. Usually your CD4 will be more than CD8. If there is a ratio reversal, you know that there is some problem. But here it did not look like the ratio looked okay. CD4 was more than CD8, and absolute values were also actually not very significantly abnormal. Okay. Yeah, if you want to see this plot, just want to complete it, CD56, these are the NK cells. So anyways, we sent the NGS, which turnaround time was nearly 20 days. We had the WASP gene mutation. So that is the Wiskott-Aldrich syndrome protein gene. Um, uh, mutation was positive. This is an X-linked disorder, and it is by a triad, which is called as thrombocytopenia, eczema, and recurrent bacterial infections. And the moment we see that the resident went back and said that we did not do a proper pedigree analysis, okay, and then when you do the pedigree analysis, you realize that the mother says that the mama had expired because of a bleeding diastasis, which they did not know of. They did not have any details. But if you look at the pedigree, you will see that the females are carriers and the males are the one which get affected. Yeah. And they have expired also, so you have to do a 3-order pedigree analysis at least. So how allergies mimic WAS and WAS distinguishes them, I have just made a table. If it is allergy, you may get secondary infection. That is common, right? However, if it is actually a immunodeficiency, the eczema will be more severe, it will be recurrent, it will be unusual distribution, it will show hemorrhagic crusting. Okay, there may be secondary infection, but it will show hemorrhagic crusting, which is due to bleeding. They are less responsive to standard dermatitis therapy. Then again, in case of atopic diseases, you may have an elevated IgEs, but it is also elevated in VOS. But at the same time, you have to get a complete panel. What happens usually when you're suspecting allergies, we will send an isolation IgE. If you do a complete panel, there will be low IgM but raised IgE. Recurrent infection, yes. Now, somebody who has atopy will tell you that they have recurrent respiratory infection as well. They will tell you बार बार खांसी होती है, जुकाम होता है, asthma है, bronchitis है. Here, the infections are going to be slightly different because you've got immunodeficiency, right? So there'll be more opportunistic infections, sometimes viral or fungal, right? Then definitely, thrombocytopenia or bleeding is not a manifestation of allergy. This child came to us with ITP thinking that atopic dermatitis is autoimmune. Here you will have low platelet. The platelet is not very low. Sometimes it may go down to 20, 30,000. But the problem is with platelet function actually, and you may have a platelet kind of bleed. Again, atopy also runs in family. So you may have a family history, but not that it is restricted to males. VOS is X-linked, so it will be restricted to males. It will be early onset, and maternal relatives possibly will be affected more. Response to therapy, you give them avoidance to a particular allergen, you give them emollients, you give them steroids, they're going to respond well. If it is an immunodeficiency, whatever you do, they're not going to respond well. So yes, for this is not a class on immunodeficiency. We are trying to look at what are the red flag signs. But just to complete my talk, you have to treat eczema by steroids, treat the secondary infection, control the bleeding. Only if there is active bleed, you do not treat the platelets. You treat the bleeding, immunoglobulin replacement, vaccination. Avoid the live vaccines if the immunodeficiency is severe, and then eventual treatment is actually hematopoietic stem cell transplant. Importantly, very, very important, you have to screen the donor when you are taking the donor for the curative, as per the curative therapy for transplant. Learning points: VOS is often misdiagnosed as severe eczema or allergy in infancy because the triad is shared: eczema, recurrent infections, usually respiratory, and elevated IgE. This may very well be there in allergic disorder. Thrombocytopenia and small platelets is the red flag sign. Importantly, interpret the CBC well. Tell your pathologist to look at the peripheral smear. Anytime you do at the CBC, it is incomplete without a peripheral smear. Immunoglobulin profile, if you send an isolation IgE, you may get it elevated and falsely call it allergy. If you do a complete profile, you may get a low IgM. Early genetic diagnosis is important for prognostication and planning of transplant. Allergic diseases may coexist, adding confusion. So, if I say we just have a table, the itching is worse. They have hemorrhagic lesions. They have partial improvement. They have more opportunistic infection, thrombocytopenia, and a bleeding history. I'm going to case two. So this is a 6-month-old infant, consanguineous parents, right? So history of consanguinity. Now, you know why am I specifying? Actually, I've summarized into one slide just in interest of the time. History was again early infancy, 6-month-old infant had severe erythroderma, generalized red skin rash. That is what the mother defined, and the resident said that there is erythematous rash, there is scaling, there is alopecia. Importantly, 6-month-old with alopecia and rash. Lot of time you may see similar thing with atopy itself, but again, now you read the, I think now we'll be able to join the dots better. Chronic diarrhea. So this patient again presented chronic diarrhea, again with failure to thrive, recurrent infection, no BCG vaccine reaction. Had a diffuse exfoliative rash, scalp thinning, loss of eyelashes, eyebrows, lymphadenopathy was there. There was mild hepatosplenomegaly and marked eosinophilia. Now you know that this patient surely will be diagnosed as allergy. Very high IgE in thousands, elevated IgG, oligoclonal. Now what is oligoclonal? Okay, so you've got B cells and T cells. So what happens that your B cell or T cell, whenever we send them for analysis, there may be oligoclonal expansion, means a particular type of B or T cells may expand abnormally. That expansion, so polyclonal is that they're actually different B or T cells. So it is like the same um, the types are same, they're all oligoclonal. However, one of the subset expands oligoclonally, and that may actually cause a problem. So this patient actually had a lower absent B cells when we did the flow, and had actually low T cells, but a particular subset of T cells were expanded oligoclonally. This was what we saw through the flow cytometry. So what we actually did was that um, uh, when you have both B and T cells absent, you start thinking of SCID. Okay. However, what happens when you have SCID and when you do a flow cytometry, you will look at CD27 and these cells may have absent representation of that. However, that was present. So we were wondering what it is like, right? So NGS gave us the answer. NGS had mutation in the RAG gene. What is RAG gene? So It is actually a recombination gene. What does it help into? When you have a B cell receptor formation, when you have B cell development, the variable region and the heavy chain or light chain that is formed due to recombination of the VDJ segments. And that recombination is helped by this particular gene. So, may it be in the T cell receptor formation or B cell receptor formation. That doesn't happen. So, the function of both B and T cells is restricted. So, uh, uh, the T cells which undergo the oligoclonal expansion, they undergo autoreactivity and then they cause this inflammatory cascade. There is autoimmune inflammation associated with rash, eosinophilia, increased IgE. B cells are totally defective, so these may present with bacterial infection, fungal infection, and viral infection. And definitely they require stem cell transplant early for survival, because by the time you diagnose them, they have already got some life threatening infection, which actually prevents them for undergoing any such treatment. So, this is actually Omen syndrome in a young infant with diffuse rash, alopecia, failure to thrive, very, very high IgE, consider Omen. They have got both B and T cell defects and very, very difficult to differentiate from SCID, where both B and T cells are affected. However, here you have the oligoclonal expansion of the T cell receptors. Early identification is very, very critical, and be cautious as they get misdiagnosed as severe eczema. I have put this pic intentionally. This pic is not of this child, but I put this because in the West their skin is white. We are a little on the brown side, or we are dark skinned, and hence the rash may initially be missed or maybe thought of as eczema or atopy. Whereas in white population, it is definitely recognized much earlier. Are allergies and PID that confusing how I have put them in the tabular form? No, actually, I will reiterate certain facts. Hemorrhagic crusting, bleeding into skin, where you see dark crust, blushed in crusting. This is more than usual for a simple eczema. Extensive distribution, refractory in nature, non-typical areas. So, toes or or lower limbs, not just flexural folds. Again, points out towards something which is more than atopy. Secondary infection, chronic scratching, immune dysfunction leads to superimposed bacterial or viral lesions, and persistence despite therapy or severity out of the proportion again points out towards something more than allergy. So, common immunodeficiencies. Inborn error of immunodeficiencies which mimic as allergies are hyper IgE, Dockade deficiency, Omen syndrome, and Wiskott-Aldrich. I may not be able to discuss all of them. uh, just some key features are that, say if your IG is more than 2000, you have got this rash and child is having recurrent infections, please think of PID and not plain allergy just on basis of IgE. STAT3 or HIES usually would present with non-immune features like skeletal and dental. They have cold abscess, they may have lung complications. Omen syndrome we have already discussed with diffuse erythroderma, alopecia, oligoclonal T cell expansion, severe immunodeficiency of B and T cells. Dockade may actually present with a prominent viral skin disease like warts or molluscosum, and severe infection. Again, it has both combined immune defects. So, if I say, how do you clinically approach, or what are the red flag features? Are early presentation, severe presentation, widespread eczema not responding to standard therapy, bleeding tendencies, early bruising, petechiae, mucosal bleeding, recurrent or severe opportunistic infection, family history. That is very, very important. Again, even if it is autosomal recessive, like like Omen syndrome is actually autosomal recessive disorder. So this was a consanguineous marriage, or if the males are affected, right? Basic hematological and immune screening includes a CBC with peripheral smear, a coagulation profile, immunoglobulin levels. We are looking at all the subset, a lymphocyte subset analysis, which has to be inferred. Remember, you infer the absolute lymphocyte count or an absolute neutrophil count in respect to the age of the child, and genetic testing or NGS, if the suspicion is strong, actually will give you the diagnosis. correlate the dermatological findings with systemic data, and management is to treat the skin lesions, monitor whatever are infections, and eventual referral to an immunologist or a hematologist for gene testing or bone marrow transplant. Uh, Take home messages: not all eczema with high IgE is atopic dermatitis. The atopic phenotype in PID can mask severe immune dysfunctions such as eosinophilia, IgE, eczema. Uh, DOCK8 deficiency is distinguished by viral skin infections and malignancy risk, that is primarily with widespread molluscum, warts, herpes, which is because of the T cell and NK cell dysfunction. Oman syndrome presents as allergy on fire, but it is actually a skid variant and it may present with life threatening infections. Um, High IgE alone is non specific and must be interpreted contextually. That is very, very important. And early recognition and genetic diagnosis enable us to curative therapy. Thank you very much.
Okay, thank you. Thank you, Dr. Payal, for that wonderful start to our session. Your talk highlighted the diagnostic traps we often fail and we often fall into, and gave us practical red flags that can help us distinguish allergy from something more serious. Thank you. Now, with that foundation, we now move to a very important next step, the immunology of recurrent and chronic infection in ENT, lungs, and skin. These are most common sites that bring children to our clinics. But when infection becomes recurrent or chronic, the underlying immunology can reveal much more. To guide us through this, I now invited Dr. Neeta Radhakrishnan. Dr. Neeta is working as an additional professor and head at the Department of Pediatric Hemato-Oncology, Postgraduate Institute of Child Health at Noida. Dr. Neeta, over to you.
Yeah, good evening, everybody. At the outset, I would like to thank Dr. Neeraj for this kind invitation. And I would like to congratulate the IAP Allergy and Immunology chapter for taking this up, because this is something which we have not been taught during our UG PG days. But when there are so many patients out there, you end up re-teaching yourself. So this is something which probably, I think, when in the days to come, this will become more and more important as well. So I've been asked to speak on the immunology and probably the workup of recurrent and chronic infections when they come with ENT, lung, and skin. Again, three common sites of recurrent infections. So what we will discuss today is what are the compartments. I think Dr. Payal has discussed it, so I will not be touching upon it much. The compartments of immune system. When do you suspect inbornness of immunity? What are the sites as in ENT, lung and skin infections? What are the common differentials? What are the common ones? What are the uncommon ones? We'll have a look at that. And then finally, how do you approach a patient who has like the stepwise approach of an ENT infection, a recurrent ENT infection, a stepwise approach to a lung and a skin infection when they're presenting with chronic infections. And finally, a little bit on management if time permits. So this is the immunological response to an infection. Like it was discussed earlier, there is an innate immune system and an adaptive immune system. Innate immune system is what we are all born with. So because so every newborn baby would also have it, and it's the first line of defense. So it's like the soldier out there who is there so he is just going to attack his counterpart just based on recognizing patterns. So it's not like there is no strategy involved. There is no planning. There is no memory, nothing like that. So it is just directly you look at if a person or somebody looks like this, I have to kill that person. So that's the only logic here. They detect pathogens through pattern recognition and they kill the cell. So it's a first line defense. It is rapid, quick defense, and it's seen even in newborn babies. It need not be acquired. Whereas adaptive immune system is something that you develop later in life. So you have T cells and B cells here. And here, the response of T cells and the
Ma'am, good evening. Ma'am, sorry, your slides are not visible, ma'am.
Huh? Why?
Ma'am, you can probably reshare them again.
Yeah.
Your
I
computer
got a
screen.
mess. I got a message also that the audience can see your slides.
Ma'am, kindly unshare and reshare once.
That's what I'm trying to do, but that share button is stuck. It is not allowing me to share. Shall I log in back again? So it's
Yes, ma'am, you can do that.
allow that.
You can do that. Yes, yes. Yeah.
I hope my audio is clear.
Yes, ma'am, your audio is clear, and your the screen is saying that the you have started sharing the screen, but it yet to come.
Okay. What about now?
Ma'am, not yet, ma'am.
Is that happening? It's moving very well here. Dr. Narish, can you take the next talk? Then I'll come. I'll
Okay, ma'am.
probably change my system
Right,
and
right, ma'am.
Okay.
not to waste others' time. Okay.
Okay.
Just,
Well,
stop share from your end because it's frozen again.
Vipul sir, please proceed.
yeah. So moving forward, now we explore an area where the immune system challenges our traditional boundaries: autoimmunity and allergy, the overlap in children. This is where the immune dysregulation can surprise us, with allergy and autoimmunity coexisting or even mimicking one another. To share the insights into this fascinating overlap, I invite Dr. Rakesh Kumar Pilani. Dr. Rakesh Pilania is working as an associate professor at the Pediatric Allergy and Immunology Unit, Advanced Pediatric Center at Chandigarh. He is affiliated with multiple prestigious institutions, including the WHO Collaborating Center for Pediatric Immunology and the ICMR Center for Excellence in Pediatric Immunology. Dr. Pilani has published over 175 papers and contributed 10 book chapters. He has also received numerous awards, including IRA, Young Rheumatologist Oration Award, and multiple Young University Award. Please join me in welcoming Dr. Rakesh to share the insights with us. Over to you, Dr. Rakesh.
Good evening, all, and good evening, Dr. Vipul. And I am thankful to the organizers for providing the opportunity. And again, this is a very apt topic to now identify that why we have to learn about the overlaps of the diseases and why it's essential to identify the overlaps of disease. So I'll start sharing my screen. Meanwhile, so hope my slides are visible
Yes, they are visible, sir.
and full slide.
Yeah.
So in next 20 minutes, I will try to show you that autoimmunity and allergies can overlap in children and which we see in commonly and like now as an immunologist which we see a primary immunodeficiency as a at our center is a and we follow more than 3000 patients with primary immunodeficiency which suggests that these disorders are nothing but uncommon actually. So I'll try to show that like now these disorders are there, and if you see the trying to see the overlaps, there may be a pointers for underlying immune dysregulation. So allergy and autoimmunities can overlap, and both allergy and autoimmunity represent an immune dysregulation, which we and in children, clinical overlap may be an early clue for an underlying inborn error of immunity, and which I'll come to that. And there are shared mechanism for allergy and autoimmunities like dysregulated T and B cell responses, impaired tolerance, and skewed cytokine profiles. And so there are several examples which we see commonly in our day-to-day practice, that eczema can be associated with autoantibodies, and asthma and allergic rhinitis can have autoimmune cytopenias, food allergies alongside thyroiditis or type 1 diabetes. So if I'll just want to show that there are several allergic diseases which we see commonly, like starting from the atopic dermatitis, asthma, which is a very common disorder in around 5 to 10% of populations in worldwide, and in our setup also, rhinitis, rhinoconjunctivitis, chronic urticaria. And if you see the autoimmune disorders, the common bread and butter, like something like as a rheumatologist, we see juvenile idiopathic arthritis, inflammatory bowel disease, and then like diabetes mellitus, which can start from early in the life, and then type 1 diabetes mellitus, celiac disease, which is in North India we see. So these disorders can be seen in isolation, but with these disorders can have overlapping symptoms, like they can have both allergic and autoimmune manifestations also. And whenever these disorders are in overlap, that it's always difficult to manage, and it's difficult to comprehend what like now the common. So why these disorders? Again, to highlight one more studies to unraveling the link between atopic dermatitis and autoimmune diseases in children. If I will see, so atopic dermatitis can be associated with several disorders like Sjogren syndrome, Angstrom, poliomyositis, vitiligo, psoriasis vulgaris, ulcerative colitis. So these disorders can have association with atopic dermatitis and overlap disorders. And but what are the reasons for this? And there can be shared underlying mechanisms or underlying genetic mechanism that are associated. And there are several genes which and HLA associations has been identified for the overlap between allergy and like. So if I will start with the like now the classical old teaching to that Th1 and Th2 skewing actually. So there are classical Th1 and Th2 paradigms suggest that Th1 response is against the intracellular pathogens. Typically, we see that Th1 response releases to the interferon gamma and TNF cytokines, and there can be macrophage activation, cytotoxicity, and typically if there is a for intracellular pathogen, this is a response. But if there is over exaggerated Th1 response, which is associated with inflammation and it links to autoimmunity, while the Th2 response, which is in response to the extracellular pathogens, something like we see parasites and commonly, and the cytokines are IL-4, IL-5, IL-13s, and IgE and eosinophils are typically elevated. But when there is an exaggerated Th2 response, which is linked to the allergy, so the typically we think, and we like now that the classical teaching before was that if there is a reciprocal inhibitions, and it's supported view that autoimmunities and allergy are mutually exclusive, which is basically not true. And what this slide shows that I don't want to like make you more complex about these disorders, but what this slide shows that there are several immune pathways and beyond the Th1 and Th2 pathways, and these Th1 and Th2 pathway can coexist also. So it is not necessary that if Th1 is higher than Th2 may not be working. So and then there are several other pathway like Th17, T regulatory pathway, and so if there is a complex over interplay play of several immune pathways related to the immune proliferance. So if I'll just simplify this diagram into the mechanistic insight why allergy and autoimmunity coexist. Something like, if you I'll just start with an allergic disorder. So due to the barrier hypothesis, something environmental toxins will causes the disrupt the epithelial junctions, that there can be barrier leak leading to the antigen entry and immune activations and chronic inflammation. So in presence of allergic disorders, autoimmunity can develop in that way. Microbiota dysbiosis like diets, antimicrobials, and loss of microbial diversities. Cytokine imbalance, we have seen that excess IL-4 and IL-13s are associated with Th2 polarization, while excess IL-17 and interferon gamma is associated with Th1 and Th17 polarization, which is for autoimmunities. And there are several genetic predisposition has been identified along with HLA, and there are several underlying inborn error of immunity like CTLA4 deficiency, IL2RA deficiency, which is also called as CD25 deficiency, STAT3 gain of function and loss of function, and FOXP3 defects. So these indicates the common immune regulatory network vulnerability in the why allergies and autoimmunity can coexist, and if they are coexisting more than if like other than the common overlaps, we can have an underlying monogenic or inborn error of immune defects. So it's important to identify the underlying IE in allergy plus autoimmunity. So if we are see the common like scenarios, that is fine, but we have to identify whenever there is allergy and autoimmunities are in conjunctions, whether we are dealing with some single disorder which is having a multiple manifestations. So red flags for inborn immunity are like early onset, they can have infancy and early childhood, severe or atypical presentation like Dr. Payal has also highlighted refractory eczema, multi-organ autoimmunity. So if you are having a refractory eczema with multi-organ autoimmunities, we have to think for a underlying immune defects, multiple immune phenotypes in the same child like allergies, autoimmunity, and infections, and family history of primary immune deficiencies. There are so again highlighting that family importance of the family history. So example of inborn error of immunity with overlap features are like CTLA4 and LRB deficiency, which can have autoimmunity, allergy, and infections. STAT3 loss of function is hyper IgE syndrome, which is typically associated with eczema, severe infections, and they can develop autoimmunity, while STAT3 gain of function is associated with typically more of autoimmune phenomena. FOXP3 defects, which is associated with IPEX syndrome, they can have a severe allergic disorders, multi-organ autoimmunity. So whenever we are having these in common or these there are overlapping disorders, then we have to identify the red flags for underlying IEIs. So why it is important to identify? Because allergy and autoimmunity in children should raise suspicion for IEI, and early recognitions allow for targeted therapy and better outcome in these patients. So the term inborn error of immunity is used in last 5 to 6 years only. The previously they have been called as a primary immune deficiency. So if we'll see the primary immune deficiency, the term suggests that it is a defect or deficiency. So but it is not true in like most of the inborn error of in primary immune defect. So there is immune dysregulations, and if you see this by diagrams, then immune deficiencies can be associated with both infections and allergies, autoimmunity, autoinflammations. They can have associated with malignancy, lymphoproliferation, and there can be a syndromic feature. So again, this is a rather I would say immune dysregulation. So it can like immune system will be working low or maybe working very high, or it is not working rather appropriately. So the term inborn immunity is signify that we can have a several overlapping presentation in a child with primary immune deficiency. So atopy in eyes can like the pathophysiology of like eye in atopy is because there is exaggerated allergic immune response to a harmless allergen, while there is inability to mount effective immune response to the pathogens which are there. So I'll discuss four cases in the next 20 10 minutes. So highlighting that these disorders are like whenever we are having a allergic disorders are there, so we should think like now when to take a primary immune deficiency or inborn nerve immunity. So this is a these are cases which has been seen at our center. So it's a Master G 13-year-old boy who presented to us in 2017. He was symptomatic since 1 year of age with itching all over body, was under dermatology follow-up and was managed with antihistamines and was well for 2 years. He was presented with itching associated with pyoderma again at 3 years of age to our center, and was followed up else for eight years and underwent also skin biopsy, which was suggestive of epidermodysplasia verruciformis, and he was referred to at our center at 13 years of age. So the family immunization and developmental histories are unremarkable in this child, while anthropometry was kind of preserved, but height was at minus 1.7 G scores, and there was no pallor, icterus, clubbing, and lymphadenopathy and edema. So if I'll see the clinical examination, there were multiple well-defined grayish papule with a verrucous surface all over the body, and multiple vesicular lesion size all over the body with central umbilication suggestive of molluscum contagiosum. So these are the photographs. These are very small lesions. If you can see, then few has a central umbilications also, typically on the hand, and again to identify that these are the small warty lesions over the whole over the body. And so this is a boy who had an extensive warts, also had eczema, and molluscum contagiosum. So in this presence, we will be thinking a combined immune defects like Docket, hyper IgE syndrome, and Viscoeldridge syndrome. While in the seeing the hemogram, there was anemia. If you see the total leukocyte count was 8,012 to 200, there was a absolute eosinophilia was there. Platelets were normal, so ruling out the Viscoeldridge syndrome. And the skin biopsy was suggestive of again epidermodysplasia verruciformis with coexisting molluscum contagiosum. So immunoglobulin profiles suggestive of IgG, A and were on higher side, while IgM was low. IgE was significantly elevated and which was more than 5,000. And when we performed the T cell subset, which suggestive of a reversal of CD4 CD8 ratio, and there was a reduced memory B cells in a B cell phenotyping. So when we perform the flow cytometry for TS17, so typically we perform TS17 for the STAT3 loss of function, but in like in all the STAT3 expression for the STAT3 loss of function and TS17 cells for all the patients who having a Docket or hyper IgE syndrome. So if you can see in the patient in comparison to the normal control in patient, there was a significantly lower TS17 cells. Then when we perform the STAT3 phosphorylation, which will be typically low, and a STAT3 loss of function, which was normal in the patient in comparison to the control. So ruling out the STAT3 loss of function in this patient. So then whole exome sequencing was performed, which showed the two pathogenic variants identified in Docket, and there was a deletion in exon 11 and exon 6, 7. So the management of these patients are like initially managed with the topical steroids, acitretin, nicotinamide, and cauterization, and started on IVIG replacement and cotrimoxazole prophylaxis, and doing well with improvement in the lesion, and we are planning for transplant in these patients. Coming to the case 2, this was a master R who is a 14-month-old. Again, he had eczematous rash all over the body since the neonatal period. So neonatal eczema, purulent bilateral ear discharge since 2 months of age, had recurrent diarrheas and purpura on the trunk since 4 months of age, and multiple episodes of epistoxis, and also had a multiple episodes of autoimmune hemolytic anemia requiring transfusion. So both allergy, infections, and autoimmunities are present in these patients. And if you see a boy that there is a significant eczema, diarrhea, and bleeding disorders, and also an autoimmunity, you will be thinking like a disorder like viscoeldridge or like. And there was a this was a second born to a non-consanguineous married couple. History of death of male cousin on maternal side at 1 month of age due to severe gastroenteritis, and was not further investigated. So again, an X-linked history was suggestive of that. So anthropometry was suggestive of weight was 7.6 kg, length like at man like appropriate at the height, and he had eczematous rash on a scalp, trunk, and extremities, ecchymosis and petechia on trunk, and hepatomegaly was 4 centimeter below right costal margin. So we have an early onset eczema, otitis, bleeding manifestations, recurrent diarrhea, significant autoimmunity, and there is a X-linked history to suggest. So like now possibly the clinical diagnosis is there of a viscoeldridge syndrome, and we just need to see the microplatelets in, and that would be more of confirmatory, and then we can confirm further for the genetic diagnosis. So child had a anemia, platelet was low, 20,000, absolute eosinophil counts were higher side, and there was a CRP was elevated, and peripheral blood was eosinophilia present, and platelet were reduced. Mean platelet volume is sometimes it's difficult when we are having a very low platelet count, and then it would be a difficult to see in the culture also. So Ig was elevated, and if you see there is a CD3 positive T cells were reduced, CD19 cells were also reduced, and then when we performed that T cell phenotyping, memory cells were CD45 RA memory cells were reduced, while sorry, naive cells were reduced, and memory cells were increased in these patients, which is typically not seen in this age. So whole exome sequencing was identified as a Viscoeldridge syndrome, exon 4 mutations, hemizygous pathogenic variant. So again, confirming that we can have a both autoimmunity and allergy and infections in a one child, and which should be investigated further. This is a case 3 who's a 5-year-old girl who was born of third degree consanguineous marriage. She was symptomatics again were very early from the life with the persistent diarrhea. She had an extensive eczema also, cervical lymphadenopathy, had a pneumonia at 2 years of age, and at 4 years of age she came with a fever with rash, BCGitis, hepatosplenomegaly, and on evaluation showed lymphopenia and elevated inflammatory parameters. So again, like there is an allergic manifestations also in anemia, and there is some lymphoproliferation to suggest in this patient. So there was a ALC which was suggestive of 1700. So again, to highlight for residents that whenever there is a less than 3000 absolutely lymphocyte count in a child of less than 1 year of age, that should be taken as a cautiously, and that is defined as an absolute lymphopenia in these children in less than 1 year age. So, and at 4 years of age, also along with the BCG-itis, he had a EBV viral load which was 1800. So when we perform the T cell immunophenotyping, because if you see the profile, there is a profile of combined immune defects in a presence of allergy, infections, and lymphoproliferations. So there was again CD45RA is a marker of naive T cells, while CD45RO is a marker of memory B cells. So typically we see a naive compartment at the birth, mostly around 70 to 80%, while in this child, naive cells are significantly reduced, while memory cells are 63%, which suggests that naive cells are very low in this child. When we because of the lymphoproliferation and allergy, we also thought of ALPS like disorder, autoimmune lymphoproliferative disorders, while the double negative T cells were perfectly normal in this child. When we performed uh, because of the suspicion of the T regulatory defects, the Tregs were assessed. So the Tregs are like we see on CD4 cells with a CD127 negative and CD25 positive cells, that in control there was a 6.62%, while in patients almost absent 0%. So highlighting that Tregs was almost absent in this child. So when we performed whole exome sequencing, which have identified that defect in the IL2RA gene, which is like a CD25 deficiencies, again highlighting tolerance defect or T regopathy in this child with the infection, allergy, and lymphoproliferations. So autoimmune lymphoproliferation. So again, highlighting that when we are having a patients with the overlapping symptoms, we should be working up these disorder for these disorders. This is the last case, and this again a 2 year 4 month old girl who was born to a non-consanguinely married couple. She was doing well till 9 months of age, and at 9 months of age, she started with a severe eczema. She had a subacute intestinal obstructions with bilious vomiting and abdominal distensions. So at that time, they thought that that is some food allergies or food, but she had a subacute intestinal obstruction, and that was subsided in its own. At 10 months of age, she had a lower respiratory tract infections requiring IV antimicrobials and nebulizations. At 9 and eczema was persistent in these patients, and at 19 months of age, she came with a lower respiratory tract infection, onychomycosis, and fungal pneumonia. And at 25 months of age, one more episode of subacute intestinal obstruction, at this time required exploratory laparotomy, and adhesiolysis was also required. She came to our center at around 2 years of age with petechiae, thrombocytopenia, DCT positivity, and Evans syndrome. So she was started on prednisolone. So when we are having infections, allergy, and autoimmunity in the form of Evans syndrome, and this was the clinical photograph at presentation. So she had a pallor. There was acral and scalp vitiligo. Oral thrush was also present, and she has a significant failure to thrive, hepatosplenomegaly, and bilateral clefts and bronchial sounds were present. So she had oral thrush, and she at this time she presented with a febrile illness. So if you see the hemogram, there was anemia, total leukocyte count was normal, while lymphocyte count, if you see absolute lymphocyte count is almost normal in this child, platelets were low, and bilirubin was elevated, and CRP was elevated. So when we performed the lymphocyte subsets, CD3 lymphocytes were significantly low in this patient, and while CD19 and CD56 were preserved. So this is a phenotype of P minus, B plus, NK minus SCID. So when we performed T cell immunophenotyping, again highlighting that the CD45RA is a marker of naive T cells, while CD45RO is a marker of a memory T cell. So in the CD45RA compartment is significantly reduced, highlighting that the T cell numbers and functions both were low, and again whole exome sequencing was I identified the RAG1 compound heterozygous defect. So RAG1 is a gene of like severe combined immunodeficiency. So a RAG can be associated with significant autoimmunity and allergic manifestations also in the patients with severe combined immunodeficiency. So if I will just summarize in next 2 3 slides, we have a primarily classical allergic diseases and in the which is highlighted in the blue, while there is a primary atopic disorders. This comes under the inborn nerve immunities like primary atopic disorders which has a underlying genetic defects. While classic allergic disease are polygenic, something like atopic dermatitis, asthma, allergic rhinitis, and associated with atopic march, they have environmental factors are in play, and there are lack of non-atopic manifestation typically in the patients with classic allergic disease, and they are responsive to conventional therapy, and the disease presentation is early childhood or at any age they can present. While the patients with primary atopic disorders, which is the topic of concern today, is that they are like typically monogenic, something like we have discussed here: hyper IgE syndrome, IPEX syndrome, viscoeldridge syndrome, and cbmopathies. They can have a severe and persistent atopy. So the run of the mill atopy is it's okay, but when we are having a difficult to treat, or they are not behaving as a conventional way of atopic disorders, and they are associated with recurrent skin and lung infections, when they are associated with connective tissue abnormalities like something like hyper IgE syndrome, or they are associated with autoimmunity and malignancy, and they have a dysregulated cytokine signaling. So these are the red flags to identify the primary atopic disorder. So if I will suggest a diagnostic algorithm, so patients presenting with predominant allergic symptoms to clinician for evaluations, we see the baseline clinical evaluation, and the red flags are that whenever we are having a severe atopy, onset of rash in the neonatal period or very early in the infancy, and if there is atypical localization of eczematous lesion. So there is a like now if you see the atopic dermatitis of viscot eldritch and the typical atopic dermatitis we see commonly, there is a difference because it's a more of generalized, and there is no typical pattern in the viscoeldridge syndrome and associated with significant autoimmunity also. And they can have eczema or asthma refractory to treatment topical therapy, and they can have a recurrent infections with unusual organisms or opportunistic infections, can have positive family history, and sometimes can like the majority of time they can have a non-atopic features like autoimmunity, alopecia, dysmorphic faces, delayed neurodevelopmental, and bleeding diathesis, skeletal or collagen vascular abnormalities. They can have a growth failure or short stature, and failure to thrive and non-responsive to conventional therapy. So if these features are present, we should work up for them monogenic allergic disease or primary atopic disorders, and genetic testing or primary immune deficiency evaluation is essential because they have a like now once you identify the underlying genetic defects, you can treat for the target, and targeted therapies are essential. While those who are having a classic allergic disease typically have onset in childhood or at any age, they are typically multifactorial, and they can have a family history, but typically the allergic disorders will be there in history in family. So monogenic primary atopic disorders can be associated under because of several underlying pathogenic mechanism, which include tolerance failure, which like now I have shown a case IL2RA defects, FOXP3 defects is also T regopathy. They can have associated metabolic disturbances like PGM3 deficiencies. They can have altered cytokine signaling, something like STAT1 defect or STAT1 deficiency, IL6ST deficiency, or STAT5B gain of function, or STAT5B loss of function, or STAT3 loss of function and gain of function. While skin barrier function dysfunctions can be associated like CARD14 defects or DSG1 defects, and while impaired TCR signaling like CBMopathies like CARD11 and MALT1 defect, and they can have impaired TCR signaling or T cell receptor signaling and cytoskeleton remodeling, typically the actinopathies like Tox and viscoeldridge syndrome and Docket deficiencies. ARPC1B has been also highlighted, and they can have a associated with the T cell repertoire restrictions. Like typically, we have seen a one case of RAG1 and RAG2 defect. So that they can be have associated with the T cell dysfunction also. So the inborn immunity spans a broad spectrum of which atopy is an important arm, and early onset, difficult to treat atopy could be a clue to underlying IEI. and other features of immune dysregulation should be actively looked for, and prompt further evaluation is essential in these patients. So the common things are common, but eyes are not uncommon, and whenever we are having an overlap and there is a like features which are highlighting for a underlying immune defect, we should be evaluated. These patients should be evaluated for that. Thank you.
Thank you, Dr. Rakesh, for that enlightening session on autoimmunity and allergy in children. You clearly showed us how immune tolerance, when disturbed, can blur lines and lead to overlapping presentations, something all of us need to keep in our mind in our pediatric practice. Okay, now I request again Dr. Anita to start the session. Yeah, your slides are visible, ma'am, now.
Thank you. My audio is also clear, right?
Yes, ma'am.
Okay. Is it okay now?
Yes, ma'am.
I'm really sorry, it has never happened before. So coming back to the talk, and I think now after Dr. Rakesh and Dr. Payal, a lot of it would be overlap, but I think a repetition is always good for learning. So what we'll briefly discuss, what is left for me is, I think, the stepwise approach to an infection, chronic infections, as well as recurrent infections in these three organ systems, ENT, lungs, and skin. So I'll briefly touch upon the rest and come to that evaluation directly. So the innate and the adaptive immune system we already heard. So you're born with your innate system, and this is your first line of defense. An adaptive system is what you acquire as you go. And so this is broadly, it's a very basic cartoon that shows us these are the compartments. And we have to start thinking of compartments of immune system when we approach these patients, because there are hardly any clues from your physical examination. So most of the other disorders, other systems that a general pediatrician or pediatrician comes across, there will be specific clues as to pick up from the system examination. But here, there's hardly much. So you have to go by a combination of history, a combination of your history, family history, what are the organisms that have been come up, and to identify which compartment, so that we get a clue as to how to we evaluate them further. So this is the differentiation between the innate and the adaptive immunity. And so again, we need to understand that so basically when we talk about recurrent infections, one of the most important part of it is going to be adaptive immune system, and that adaptive system has both B cells and T cells. And based on where the abnormality is, that is how the manifestations also is going to differ. So these are in broad the how inborn errors of immunity present to us. You just heard about how immune dysregulation happens, and before that you heard our allergy presentation is there. So commonly infections were the primary manifestation, as in from where you could pick up a patient with inborn error of immunity. But increasingly now we identify it with autoimmunity, patients who are allergic, patients who are presenting with malignancy, marrow failure, lymphoproliferation, autoinflammation. So these are all different presentations of children who are coming with primary immune deficiencies. And this is the group of IUIS classification. So it was recently updated, and I think around 500 odd monogenic disorders now come under these headings. It's either is under one of these different sections of inborn errors of immunity. And we will kind of decode it a bit and see for which compartment what investigation needs to be sent. So like I said, any of those bubbles could mean inborn error of immunity, but we are going to look at only infection allergies today. And infections, recurrent infections already discussed. If it's a single infection, so although that we'll see that warning signs also which have been brought out by the Jeffrey Model Foundation, but they are essentially for lay public to come to a hospital. It's not for a pediatrician to decide whether to evaluate or not. So sometimes if you have a single episode, for example, a liver abscess, single episode will warrant an evaluation. A patient who has an unusual abscess, patient who has an abscess which has an unusual organism, unusual severity, all of this we will evaluate. Patients who come with suspected allergies, again, very important. A lot of kids whom we pick up later as, say, SCID or one of the combined immune deficiencies would have already gone through gastroenterologists, dermatologists, etc., and would have had a label of allergy, milk allergy, or some kind of allergic diagnosis which is there. So if a patient is coming with allergy and infections, then definitely think of it. And failure to thrive. So among the 10 warning signs in Jeffrey Model Foundation, growth failure is one of the biggest diagnostic clues, as in clinical clues to get to a further evaluation. And growth failure could mean a lot of other things as well. So we'll see stepwise as to how do we evaluate. And like allergies was already shown, early onset of a allergy, a patient who is resistant to first line of treatment, and multiple lines of allergies, allergy with infection, etc. This is the paper that Dr. Payal also showed. And I think 2 centers which reported data from India was PJ Chandigarh and ourselves. And we, from all the patients which were in the cohort where they analyzed the allergic presentation of inborn errors of immunity, that it is generally the frequency of allergic reactions to the tune of around 30%, around 25% patients would have, in inborn error of immunity patient would have had allergy as a presentation. And this could be, among all the allergies, it could be asthma, it could be atopic dermatitis, it could be allergic rhinitis, it could be anaphylaxis, it could be any one of those allergy diagnoses as well. And finally, patients who presented initially as allergic disease would have there is a diagnostic lag in patients as well. So that both ways there would be a diagnostic lag, because you're so like focused, like Dr. Vipul mentioned in the beginning, that you're so focused on allergy that you're not thinking about anything else. It happens at times, and then finally when a diagnosis is made based upon a simple CBC and an immunoglobulin profile, it sometimes we would have lost a lot of time in trying to change the different type of milk and things like that in the process. So whenever we evaluate, it has to be a very systematic way of evaluation. So this is the 10 warning signs both for children and adults which they have brought out. And like I said, it's a very broad broad outline. It does not really mean that you have to follow it exactly. Many a times you will, even one septic shock episode, even one episode which is very bad dengue with HLH, etc., we may end up evaluating for underlying primary HLH. So it could be there in any age as well. So it is a myth that it is there in children only. So if you are seeing, we have adult colleagues who are managing allergies as well, we should be telling them that they should evaluate. So now what are the presentations of recurrent and chronic infections in children? In upper ENT as well as upper airway disorders, it is usually otitis media, sinusitis. So that whole sinopulmonary infection is a very common presentation in antibody deficiencies. So patients come with recurrent otitis media, sinusitis, sometimes chronic rhinitis. So those upper respiratory symptoms never go away. Some other kind of disorders can also present with tonsillitis, recurrent pharyngitis, adenoid hypertrophy, etc. So this could be a clinical presentation. Patients can present with lung and lower respiratory tract infections. Again, recurrent pneumonia, a child who's wheezy child who's never improving in between, a patient who presents with bronchiectasis. Again, antibody deficiency, recurrent pneumonias. By the time we pick them up at 6 or 7 years of age, usually they have already bronchiectasis on board. And by the time they are like, that's a sad fact in India, that by the time they are around 10 years plus, they may be, they'll be mildly hypoxic and romer. And then by the time they are 15, 20 years on, then they would require oxygen at home and things like that. And it's one of the reasons for lung transplant in the West. In India, that is not a very possible, as in it's not a very feasible option for patients. So patients coming in with recurrent respiratory infections, pneumonia, bronchitis, wheeze, persistent infiltrates in the lung, we should think about immune deficiencies as well as a whole lot of other pulmonology conditions as well. Skin and soft tissue infections, it could be boils, abscesses, cellulitis, impetigo. I think some of the pictures were already shown. Chronic eczema, chronic fungal infections, warts, chronic mucocutaneous candidiasis, molluscum, all of them comes under this group of chronic and recurrent infections, and we'll see how to evaluate. So what are the 4 pillars of management is we have to, from the history, we have to see the age of onset of the symptoms, whether it is a gender can help us, whether family history can help us, is there any other member affected, is there consanguinity or not, and which immune compartment is affected. Let's try and break it down. So clinically, there's nothing really helpful. Many a times it's just failure to thrive. Many a times it is a sequelae of the infection only, like some fistula or some kind of skin rash, etc. you will pick up. Lymph nodes and tonsils you could look for. Patients who have antibody deficiencies will have absent, as in some of them will have absent lymph nodes and tonsils. Hair, skin can give us clues. Skin, especially because the eczema, the chronic infections, chronic molluscum, warts, etc., can give us clues. And hair, hypopigmented hair can also be helpful in certain conditions. Organomegaly, if it is there, may be helpful in certain conditions, like the woman which was shown earlier. It can have chronic, as in hepatosplenomegaly. Some of the immune dysregulation symptoms, like ALPS, etc., can have chronic splenomegaly. Any other phenotypic features you would look for, and we look at try to find out the focus of infection. So evaluation essentially is twofold. One is evaluation for the underlying immunological evaluation, and the second group would be microbiological evaluation, because we need to know what bug it is, and that knowledge of what bug is causing this actually helps us narrow down the compartment further. The age of onset, why is it important? Like I said, if it is very early, it is usually either an innate immune defect, like for example, patients who have severe neutropenia or patients who have X-linked CJD, etc., comes in early presentation. It can be patients who have severe combined immunodeficiency, which have T cells are absent in that group of patients. They also present very early with infection. So this is like a newborn baby who has come with infection, or maybe 2, 3, 4 months of age, the baby is in the ICU requiring oxygen. That kind of presentation is common. Even pneumonia presentations, chronic diarrhea presentations are also there. But like for this talk, we will restrict it to the ENT, lung and skin infections. After 6 months, if the baby was absolutely well till 6 months, and then symptoms started after 6 months, usually 8, 9 months of age. So then what happens is, it's the usual first 6 months were protected by the maternal immunoglobulins. And then when the baby had to produce his or her own immunoglobulin, then because there is absence of immunoglobulin, then patient comes with infections. So these are usually cyanopulmonary infections. And here again, common is X-linked agammaglobulinemia. Some of the combined immunodeficiencies can also present it, which they are not very severe to present early, but they start presenting after 6 months of age. And some of the other disorders like Viscott, ataxia, etc., can also start manifesting at this point in time. And finally, anybody above 5 years, again, it could still be a primary immune deficiency. It does not, nothing really at any age can be affected. So it could be patients with CVID, patients with primary antibody deficiency, specific antibody deficiencies, patients with complement disorders. Some of the other immune dysregulations also can present at this point. So child coming in with say hypothyroidism or diabetes, all of those presentations also is common in patients after 5 years with in this group of disorders, this immune dysregulation group of disorders. Gender, I've already mentioned so many disorders which are X-linked, and third generation pedigree chart is important. Based on the type of infection which is there, that gives us a clue to the compartment. So T cells are like the dawn of the immune system. So if your T cell is affected, T cells actually, if there is severe T cell deficiency, it can actually impact, it can cause viral infections, it can cause bacterial, it can cause fungal, it can cause PCP infections. Any of these infections are common with T cell disorders. B cell deficiencies generally present with bacterial infections, and again specific infections like pneumococcus, H. influenzae are common. Some of the gut infections which are common is Giardia. And then B cells can also cause viral infections, especially enteroviral meningitis can be there. So children who take polio, they can actually cause neurovirulence and cause neurological manifestations can be seen in these children, because they cannot remove, they chronically shed OPV, and during this chronic shedding, the virus actually mutates and attains virulence. And finally, the phagocytic group of disorders. Phagocytes means neutrophil macrophages. So here in this group of disorders, it can be patients who are severely neutropenic, or you can have very high neutrophils like in leukocyte adhesion deficiency, but the neutrophils are not functionally well because they cannot reach the site of inflammation. So in this whole group of disorders, it is usually gram-positive, gram-negative infections that you see, and certain fungi like Aspergillus, Candida, etc. Mainly mold infections like Aspergillus are common in severe neutropenic disorders. So these are the organisms here again. So from this basis, we know how which compartment is affected so that we can evaluate it further. So B deficiencies again, bacterial, protozoa, viral. And what evaluation will you do? First evaluation is always CBC. Second is always immunoglobulin profile. So very, very simple things to be done routinely. And after this point, if there is a clue for this, like especially immunoglobulin profile, if shows low IgG or maybe low IgG, AM is low, or sometimes GA is low, M is normal, or M is high. So all of these presentations can come here. And here, then you go ahead and do a lymphocyte subset analysis, and especially the B cell enumeration is done. And further, if you want to have, so suppose if your reports aren't good, then there are many ways to look at whether there is any functional response of the B cell. So antibody response to vaccinations is one of it. It used to be done much more earlier, I feel, but now with the advent of genetic testing, after this step, I think most of us would straight away get a genetic evaluation done because it's tedious to get the further testing done. Similarly, in T cells I said always because it is the dawn, so it is going to cause bacterial, viral, fungal, protozoa, or mycobacteria. Any of these infections can be seen in T cell disorders. To T cell again, stepwise evaluation, complete blood count, immunoglobulin profile would be similar. Lymphocyte subset analysis will show you which subset of lymphocyte is low, whether it is T, B, or NK. And from that pattern, you can understand which group of genetic disorders is it going to be. So severe combined immune deficiency is not a single disorder. The multiple genetic disorders which come under that, but it gives you the pattern gives us a clue as to which type of SCID it could be. And then there are so many other specialized investigations as well. A big clue to T cell disorders are the failing to thrive babies, chronic diarrhea, chronic thrush. This is the kind of presentation that you would see. In patients who come with innate immune disorders, here complement set of disorders. Complement we all know essentially because we have been all taught that terminal complement pathway defects will cause meningitis. So that is something which we all remember. Again, splenic function, etc. We've been all taught. All of that we generally are exposed to during our MD days. So bacteria, patients who have bacterial infections as for antibody deficiency, but there will be meningitis, the Neisseria meningitis also now. And generally no viral, fungal, protozoal, etc. with complement disorders. And phagocytic disorders, like I mentioned earlier, it's usually bacteria and encapsulated organisms. So they are also common in this group of patients. For example, Burkholderia, patients with Serratia, and unusual organisms. If somebody comes up with like Nocardia, Elizabeth Kingella, etc., then you have to think of specific phagocytic disorders like patients having CGD. So here what evaluation will we do? Your CBC will essentially be normal unless you have going to the neutropenic group of disorders. The rest of it generally in phagocytic disorder, unless it is severe combined neutropenia group, everything else has neutrophilia. So if neutropenia, you do bone marrow evaluation. But in neutrophilia, then essentially you have to get to nitroblue tetrasodium and dihydrorhodamine test. These are two tests which will rule out or rule in CGD. And sometimes if the TLC is very high in absolute neutrophil count is like 30,000, 40,000, then again flow cytometry for LAD, leukocyte addition disorders can be done. So again, very simple evaluation, neutropenia yes or neutropenia no. And if there is neutropenia, then definitely go ahead, do the marrow. And if there is no neutropenia, first test is NBT-DHR. And if NBT-DHR is not showing us which is coming at a normal, rule out LAD if it is very high, and otherwise there are again many more other disorders also. After this point, generally we go ahead with the whole exome sequencing. And finally, complement disorders, we get the complement level CH50, H50 done. So in ENT disorders, so patients who comes to you with recurrent ENT infection, so 2 episodes of otitis media. So it is not a very rare condition at all in pediatric practice. So even bottle feeding can cause ENT infections. Patients who have adenoid hypertrophy causes ENT infection. So for a astute pediatrician to differentiate between the common causes and the uncommon cause is what the whole the trick in the whole game is. Because this is something which will probably be seen out of 1,999 will be common causes. So that rather than over investigating, we have to be very, very prudent as to how to evaluate. Once you get to a diagnosis, it's very easy to say, okay, this is how to do and stuff like that. But before that, you're going to see 999 patients before you get to a diagnosis. So that is the idea of getting to a stepwise evaluation. So it could be chronic sinusitis, GER. We have been all talked about. We have talked about this. Even patients who are going to in a crowded places, patients have recurrent infections because of a lot of these reasons as well. In the immune causes, if a patient is coming with recurrent ENT infection, the most common you will think about is antibody deficiencies. And in that antibody deficiency, X-linked agammaglobulinemia is one, and CVID would be the second. And certain other conditions can also cause this. Now, when do you suspect in the ENT infection? So if an ENT infection is serious enough, if it is there is for more than, these are general guidelines again, you could evaluate earlier as well. Patient is not growing. So I think that is the biggest clue. If patient is not growing, evaluate quickly. If there is a family history, evaluate quickly. Otherwise, and if a patient who's never seems to be getting better, as in one infection over without much gap, again the next infection has come, these are all reasons to evaluate. What about lung and lower respiratory tract? Again, common conditions, so many of them. Starting from newborn period, if there is recurrent pneumonia, you have so many conditions, congenital anomalies in the lung that could cause it. The tracheoesophageal fistula could cause it. Patients who have GR again, neuromuscular disorders, cystic fibrosis, ciliary dyskinesia, asthma. Again, recurrent respiratory symptoms are common. Among the immune system, here again antibody deficiencies top the list, and after this you will have combined immune deficiencies, and finally CGD group of disorders also present with persistent pneumonia or recurrent episodes of pneumonia in these patients. So again, here again dictum is failing to thrive, evaluate. Patients who have allergy with lung infections, infection with an allergy, evaluate. Patients who have had a family history, consanguinity, evaluate early. If that ENT infection is associated with something else, for example, you have recurrent sinusitis with an immune thrombocytopenia, or if you have recurrent infections in the lung plus the gut. So there are two systems involved. Again, high chances that there is a systemic disorder which is causing all of this. And finally, unusual organisms. If you're able to culture something in the sputum or in the, if you have taken aspirate something where it is growing nocardia or something like that, again evaluate. BAL is growing pneumocystis, definite diagnosis that there is an immune deficiency. And skin soft tissue infections, a lot of things which we attribute to hygiene, a lot of things which we attribute to malnutrition as well. So all of that apart, from an from a immune deficiency point of view, it could be many disorders. Lot of leukocyte adhesion disorders come with skin infections. CGDs can come with skin infections, and many of the other viral infections that were shown earlier can also come. We'll see pictures a little later from now. So whenever you have, again, other system involvement, failure to thrive, patients who have bony involvement, as in it could be skin plus bone involvement, mucocutaneous candidiasis, evaluate early for primary infections. So how do you do a stepwise evaluation? So in recurrent infections, you always ask for the onset, the ear, nose, throat evaluation, family history, growth pattern, allergic symptoms. If you're thinking of adenoid, you evaluate according to. And common non-immune causes, I don't need to detail how to evaluate it, but you're going to look at allergic causes, anatomical defects, environmental factors, and functional causes. At the basic evaluation step, you'll be doing a CBC, immunoglobulin profile, and even for the other ENT causes, you may have to do the allergen testing, you may have to get an ENT specialist to look at paranasal sinus, even an endoscopy at times may be required. From an immune deficiency standpoint, immunoglobulin profile and sometimes even subclass levels may be required. And if there is nothing else that is coming out, if you're not getting anything other than that, generally we do whole exome early because it's quite difficult to get a complement level, etc. done. But earlier when whole exome never used to be, it used to be difficult to get a genetic evaluation. At that point, a lot of us would do screening for complement as well at that point. So here is a 2-year-old boy who's had a significant family history. There is non-consanguinity, but family history of maternal uncle having died at 7 months of age due to frequent infection, and another mother's cousin who has died in infancy following some boils on the chest, so probably an infection as well. So here he had normal birth weight, but he is symptomatic only from 9 months of age. So we discussed that after 6 months, it is either antibody deficiencies or some of the combined immune deficiencies which are not severe enough to come early, or it could be CGD group of disorders that present in this spectrum. So here his presentation has been respiratory illnesses with otitis media. So it's only 2 episodes of otitis media and 1 episode of admission for fever where blood culture grew strep pneumonia. So again, extremely suspicious for an underlying immune deficiency, especially with the family history of male members being affected. So these are the 3 differentials we kept like this. So here on examination, there's nothing very remarkable except for the skin rash. This skin rash is like there's a violaceous rash which is slightly elevated. It is not really an infective rash, and later we biopsied it. It turned out to be vasculitic rash. And here again, once we ran the evaluation, so these are the investigations that we did in the same order that we did. So complete blood count, absolute lymphocyte count was actually normal. So like it was discussed earlier, any infant, you less than 3000 run a lymphocyte subset, an older child 1500 would be the cutoff, but here it was much more than that. So really didn't look like SCID at that point of time. Immunoglobulin levels, but showed little less G. The rest of it was again normal. So it's again not much of clues. We did run a lymphocyte subset, and that subset analysis also showed little less CD4 actually. Nothing else came up here. So these are actual difficult scenarios. So many times when we teach, if you have a very garden variety, it would be very easy to pick up. But many times when we evaluate 9 out of 10 times, it will be something complicated like this. If something is low here, something is low. It could be even acquired low also. So there are patients who have CMV who can have a lot of cytopenias, especially T cytopenias, which can be there. So here, again, whole exome picked up the diagnosis. The flow was done at NIH Mumbai, but the whole exome later picked up it was again a SCID mutation only, IL2RG, X-linked SCID only, but it is a new variant, and that novel variant was actually not as severe as the usual variety, and that's probably why he was diagnosed a bit late. So any suspicion of otitis media, pneumonia, sinusitis, this group of presentation, these are the 3 things in this stepwise order that you should be looking at. What about recurrent or chronic lung infections? Again, we said detailed history, rule out common non-immune causes. Again, you would know better than me how to evaluate for GERD or how to evaluate for asthma, cystic fibrosis, etc. You should try and reduce all the antigenic exposures also, like reduce tobacco, smoke, pollution, and whatever you can do and modify. Let us try all that. After this, the next evaluation from a pulmonology standpoint would be a sweat chloride and evaluation for cystic fibrosis, X-ray and ESR, etc. to look at inflammation. From an immunological standpoint, again, same investigations, immunoglobulin profile subsets are done, and HIV is generally ruled out. And many a times, if you don't get a diagnosis in that, so suppose in lymphocyte numbers are normal, immunoglobulins are normal, or IgG is on the higher side, then you will straight away go ahead for a CGD evaluation at this point, complement levels and things like that. So again, certain patients, so lung infections, thymus is almost not there. Patients who have come with eczema, lymphadenopathy, lung infections turned out to be SCID group of disorders. So this is how a subset. So this is a very nice SCID. You can just to put it up so that it's very, very representative SCID. So you can see the CD3 numbers. Earlier, the earlier case actually had a normal lymphocyte count. Here you can see the lymphocyte count are less than 1,000, 758. This is also around 1.5-year-old child. CD3 is absent. NK cells are absent, and CD19 is present. So it is T minus B plus NK minus presentation. So this is how it looks like. Another baby, so that just to show the same picture actually, just to show the lymphopenia. Ataxia telangiectasia, again telangiectasia comes in later. So many a times it's a child who's coming back to you with recurrent infections, but that infection, earlier it is just clumsiness at times, and you don't get all the features of an AT earlier in the course of presentation. And later, in retrospect, everybody is wiser, but this is the whole idea is to pick it up very early. These are common presentations. And another patient, again, 5-month-old baby. So this was actually last year. This baby was actually referred to us as kid, recurrent respiratory infections, recurrent diarrhea, weighs only 4 kilos at 5 months. Very sick, emaciated baby. And nothing was remarkable except for FTT. Ran a lymphocyte subset. Subset also came back as normal. Really clueless. So we thought it could be one of the other combined immune disorders. And so rather than spending on a longish, as in extended lymphocyte panel, got a molecular done, and molecular came out to be actually cystic fibrosis. So that the whole evaluation pathway, as in before the child should come to us, the child should have had an evaluation with the pulmonology team. And here again, because of chronic diarrhea, you can have secondary IgG-AM low as well. So that is also a common presentation. And finally, skin and soft tissue infections. So these are the various skin presentations in this thing. Recurrent candida or patients who come with abscesses, etc. So here, like we discussed earlier, it could be secondary infection because of eczema. It could be hygiene issues, malnutrition, seborrhea. So all of these issues can also be there. General evaluation steps are similar. It's just that here, your phagocytic group of disorders you should think about a little earlier. Should look out for all chronic conditions, as in secondary conditions you will rule out. And many a times it is not infection also. It could be neutrophilic dermatosis. You're seeing recurrent infections on the chest and the legs, etc. Recurrent pustules. But then when you look at it, it could be a sterile abscess and there is nothing else in that. So it is a neutrophilic disorder which is causing this neutrophilic dermatosis. So the tests are again similar. So this is again just running through images. So this is viscot, bad cellulitis, eczema. Then here again, leukocyte adhesion disorder, bad areas of necrosis, no pus at all. Patient with chronic warts. So this child actually had a myeloid leukemia later. So this kind of skin pickup, we didn't pick it up at that point of time. When we retrospectively diagnosed the child, this one was later understood that it was wart. Skin infections, chronic draining ulcers, they are always abnormal. So you take out the pus, look at it. So here you can see that it actually became a chronic osteomyelitis because of that skin infection. And this was also a viscot baby. Then severe congenital neutropenia, you can see those abscesses, actually they don't have pus in it because there is no neutrophil in it. So it is just serosanguinous fluid that comes out of it. And then that later, that serosanguinous fluid, when you culture, some bug would grow out of it. It's usually gram positive or gram negative. And then she had a similar one in her perianal area, which ultimately led to that whole area had to be debrided, and there is a colostomy draining it. Another child with severe congenital neutropenia, you can see the nose, the infection in the nose, and a palate which actually perforated. The palate perforation was from a fungal infection. Both have Elaine mutation. And this is not infection as such, but I thought since it's dermatology, we should also show that this kind of vitiligo with autoimmunity, think of immune deficiency, patient with recurrent skin rashes like this. So this is actually skin rash, bony pains, came to us for anemia actually, and later evaluation turned out to be, again, this is an autoinflammatory kind of disorder called Majid syndrome. So these are actually neutrophilic dermatosis that is there. So whenever you have recurrent pyogenic infections, non-immune causes a huge group of disorders, but after you rule out all the non-immune causes, PID possibilities, essentially phagocytic disorders, some innate immune disorders, and of course, if it is viral or things like that, docket, HIES, etc., should be thought about. So this I think we have done. And finally, come to the shift in management process. So now, earlier it was only best supportive care that we could give our patients, but now a lot of shifting has happened, a lot of treatment options now, not just for infection as well as allergies. A lot of inflammation is being treated. I think there is a session on targeted treatment coming up. And then finally, the replacement, the immune reconstitution is something which we can offer through transplant as well as through gene therapy. So that infection part of it, two major parts, preventing infection by either immunoglobulin replacement or by immunization. So pediatrician again they always ask what all can we immunize, what all should we give as immunization. Some of them should not be given. Again, live viral vaccines are not given in patients who have combined immune deficiencies. So we'll come to that. So immunoglobulin replacement, it can be IV immunoglobulin replacement or sub-Q immunoglobulin replacement. Both of it is available in our country. There are two different types of sub-Q immunoglobulin replacement as well. So the cost would be almost similar. And then we do give patients who have breakthrough. So if you have antibody deficiency and on IVIG prophylaxis, if there is breakthrough infections, we can add an antibiotic based on which compartment is affected. The antibiotic or antimicrobial of choice would change. PCP prophylaxis is given to all patients who have T cell deficiencies. And finally, transplant. For everything in red, transplant is a cure. So among all the IUIS classification, I think more than half of those group of disorders require transplant, as in can be cured by transplant. So that then send them early for transplant. And so there are a lot of myths about transplant also. So as pediatricians who refer patients, now you don't need a full match. Even a half match donor can be taken. Funding is not an issue anymore because most of the government organizations will fund transplant, and no blood group restrictions, etc. And nothing will happen to the donor. So these things, when they come from the primary pediatrician, it is always helpful. And in immunization, based on the type of immune defect, your immunization, what is so this is again free access. It is available. So you can just look it up, what is contraindicated and what should be given to these patients. So with that, I think I'll stop. Just concluding that diagnosis should be done before it's too late. Many a times when we pick it up after bronchiectasis sets in, it becomes very difficult to treat even with IgG replacement, or even patients who have had really bad couple of episodes of meningitis, etc. They may become, their sequelae are quite bad. So diagnose before early. Allergies are a very common presentation of IEI, and try and diagnose. And many, again, a warning why I've written correctly is because with the advent of this testing, which is genetic testing, which is freely available, a lot of these variants of uncertain significance get reported, and we really need functional correlation, or we really need help of our genetics colleagues to understand, help us understand whether that mutation, whatever they have shown, is actually the pathogenic one, or have we missed another one. So I've had a couple of patients who were actually referred as immune deficiency with a heterozygous mutation in a condition which was autosomal recessive. And later, when the raw data was reanalyzed by our genetics, it turned out to be something else. So these things are common, and we should not label them just based on the basis of a VUS. I'll stop here, and I'm happy to take any questions. Thank you.
Thank you, Dr. Neeta, for the excellent and practical talk on recurrent and chronic infections. You gave us a clear lens to look at ENT, lung and skin infection, how immune mechanisms shape up their patterns. This is the knowledge we can immediately apply in our clinics. Now, to conclude our session, we now move into exciting frontier of therapies, biological and immunotherapy, how they work. This is the science that is reshaping pediatric allergy and immunology, moving us from conventional treatment to precise targeted care. I now welcome Dr. P.C. Kathuria to take us through the evolving and powerful field. Dr. Kathuria is a senior consultant in the Department of Allergy and Asthma at the National Allergy Center and PLK Max Hospital, Saket. With over 42 years of clinical experience, Dr. Kathuria has been the post-director of National Workshop on Allergy Testing and Immunotherapy and has delivered talks at numerous national and international conferences. He is the author of many books with more than 70 publications, including research articles, reviews, and abstracts, and has contributed extensively to the book chapter and journal in the field of allergy. He has been recognized with prestigious honors, including Dr. R.K. Modi Memorial Lecture, Shipu Memorial Oration, and Sardari Lal Dr. B.K. Oration Award. I welcome Dr. Kathuria to deliver his talk on the biological and targeted immunotherapy and how they work. Over to Dr. Kathuria, please, sir.
Good evening, everybody. Am I audible?
Yes, sir.
My greetings to all friends, ladies and gentlemen. It is indeed a pride for me to share my thoughts on biological, anti-IgE, alpha, receptor IL-4, anti-IL-4, RA, anti-IL-5, alpha receptor anti-IL-5, and anti-TSLP. Along with the target allergen immunotherapy, how they work. I compliment Dr. Neeraj Gupta and all my presenters who were initially Dr. Parul, Dr. Neeta, Dr. Rakesh for their wonderful presentation. I am a clinician, respiratory man, so my focus will be on basically on the respiratory allergic asthma disease. Allergen immunotherapy started way back in 1910, more than 110 years ago. Subcutaneous immunotherapy has withstood the test of the time. While the sublingual immunotherapy came in 1986, well accepted, equally effective in immunosensitized patients with standardized product formulations, but less effective in a comorbidity. The biological came in 2003, omalizumab, and the dupilumab came in 2022. In between came the mepolizumab and the benralizumab, anti-IL-5 and anti-IL-5 receptor. Recently, the FDA has approved dupilumab in a 6-month-old child in atopic dermatitis, and also the omalizumab has been approved by FDA in food allergy in a 1-year-old child. Friends, we have come a long way from the symptom control in 2025 to the clinical remission, which is defined as a sustained responsiveness to the symptom control, improvement in the FEV1 with no exacerbations, no need of OCS, and increase the quality of the life for a minimum period of the 12 months. The future is to achieve the complete remission. Means not only the symptoms control of the 4 parameters as we explained, but along with the decrease in the remodeling, as well as the normalizations of the lung function, which is still not possible if we combine both the biological as well as the allergen immunotherapy. If you want to understand how to achieve the clinical remission, one must know what is type 2 inflammation. As already explained by Dr. Rakesh, type 2 inflammations comprises of the 6 diseases: allergic rhinitis, allergic rhinosinusitis, allergic asthma, atopic dermatitis, food allergy, as well as the eosinophilic esophagitis. And it is the interaction of the cytokines from the Th2, IL-4, 5, and 13, as well as the cytokines from the ILC2, IL-5, and 13, which is responsible for the ongoing inflammation, while the type 1 and type 3 belongs to the autoimmune disease and the infective disorders. But our allergic disorders, type 2, primarily is due to the environmental along with the genetically predisposition factors, where the cytokines, they go on perpetual inflammation. In response to the allergic asthma, immunologically we define on the base of it whether my patient belongs to the mild intermittent asthma, persistent intermittent, or severe asthma. Means mild intermittent asthma means there is infiltration of only the mast cells. Here the priming effect of the eosinophil occurs. We give LAVA and ICS, patient's response get relief. But there is no remodeling. While in case of the persistent asthma, not only the mast cells degranulation, but also the eosinophilic cell degranulation, along with the cytokines of the ILC2 and Th2, they interact and they're responsible for the ongoing inflammation. Here, even if we give the high dose of ICS, along with the off and on of the OCS, patients may not respond. Because of the remodeling as well as the inflammations, they either go parallel or one is predominant and one is less predominant. And in case of the severe asthma, where the remodeling has an upper hand, as we know, the remodeling has a 5 factors. It is a epithelial dysfunction. It is the increase in the mucous hypertrophy. There is a submucosal fibrosis. There is a basement membrane thickening. There is increase in the airway smooth muscle mass. So some of these parameters of the remodeling are reversible, where the biological effect, while some are irreversible. That's why these patients, they have got a lifelong disease. But if you talk of that T2 inflammation, high T2 inflammation, it is a heterogeneous in nature. Many exacerbations, many times need of the OCS. But some of these patients, they respond. If you avoid the trigger factors, they get into the remission. But there is a red flag that how to check, how to diagnose that there is no remodeling, but there is only the inflammation. And this is possible only in the mild intermittent asthma, not in case of the persistent asthma or a severe asthma. So aim is to achieve a clinical remission if we select those patients, those who have got a mild intermittent asthma or with a history of the comorbidities others like rhinitis or atopic dermatitis or food allergy. Friends, allergic asthma, there is no question of allergen immunotherapy. It is highly indicated in a high T2 inflammation, Ig mediated, with or without eosinophilia or with or without high pheno. But if you start allergen immunotherapy, it is a complex journey of 3 years. It is a effective allergen dose dependent. It is a duration dependent for minimum period of 3 years, and it needs standardized product formulation. And during this journey of the allergen immunotherapy, the most important factor is the standardized product, and most of these patients, they get adverse effect and they have got a poor adherence to therapy. If you focus on all over the world, 25% of the patients of allergic disorders, especially of the high T2 inflammatory disease, they are on allergen immunotherapy. Among these, 15% only they follow up to the 3 years adherence to the therapy. Because during this journey of the allergen immunotherapy, most of these patients, they have got adverse events. To build up the dose, you need 20 weeks. And then every month you have to take a shot for a minimum period of 3 to 5 years. Product formulation is the most important in 2025. But these extracts are given in a pathological conditions, those who have a high level of high T2 inflammation. And these allergen extracts not only contain the proteins, but they also contain the protease. And both these protein and the protease, they dysfunctions our innate as well as the acquired immune system. Especially these allergens, they have been found to induce more emergencies, more hospitalizations. There are limitations also because 80% of the patients we found in our practice, they are polysensitized, not only to the aeroallergens, but also to the food allergens. And most of these patients, they have got a comorbidities. 50% of the patients, they have allergic rhinitis, allergic rhinosinusitis, atopic dermatitis. Look at the GINA guidelines. In each step of the GINA guidelines, step 1, 15% uncontrolled. In step 4 and 5, more than 50 to 60%, we have uncontrolled asthma. Not only this, after the age of 40 years, most of the patients, they have got a non-allergic comorbidities like hypertension, obesity, and OSC. So product formulation which we use for allergen immunotherapy is the most important. If we use the crude extracts, most of our patients, they stop on the way. But if you use the standardized product, they will continue. So it need is there to decrease the allergenicity of the product formulation and increase the immunogenicity. How we increase the immunogenicity? It is possible only if we add biologic along with the allergen immunotherapy. Allergen immunotherapy is an immune modifier. It activates certain immunoprotective cytokines, IL-10, IL-35, TGF-beta, immunoregulatory antibodies, IgG4, secretory IgA. At the same time, biological act on the inflammation. It will decrease the inflammation. It is a immunogenic. So combination of allergen immunotherapy and the biologics is a additive as well as synergistic. The first time used in 2011 practice parameter says that omalizumab used in combination with the immunotherapy has been shown to be effective in improving symptom score compared to the immunotherapy. It induces early and rapid response to the symptoms, induces enhanced tolerance to the allergen extract. It has got a steroid sparing effect, it improves the quality of the life, and it has got a disease modifying effect. Recently, it's been found initially there was no drug which can re-epithelize, and it is the only allergen immunotherapy which can re-epithelize the damaged epithelial lining and the production of the immunoregulatory factor. So friends, we have got certain standardized products available in India. Dust mite available has been found in certain studies that it also acts as an antiviral and an immune remodeling decreases. The function of a allergen immunotherapy in a first year, why we give for 3 years? Because in the first year, there is a decrease in the density and the activity of the effector cells, EH2 cells, B cells, ILC2 cells. Their density of the IE receptors decreases once we give allergen immunotherapy along with the biological. The second year, there is a synthesis of the immunoregulatory cytokines, IL-10, IL-35, TGF-beta, IgG4, and IgA. Now, once the interferon gamma gets increases, and in the last phase, in the last third year, there is a synthesis of the immunoregulatory reg cells, Treg cells, Breg cells, ILC2 reg cells. Once these immunoregulatory cells are synthesized, then it has got a long-lasting effect. That is why the allergen immunotherapy is minimum period for 3 years. If you add biological along with the allergen immunotherapy, then the process is more enhanced. Immunoregulatory system is more enhanced and rapid. AIT decreases airway epithelial apoptosis and repair the impaired epithelial tight junction. Subcutaneous immunotherapy and sublingual immunotherapy, equally effective, but only difference depend on the comorbidity. There are 4 potential positive points. Both AIT and biological increase the AIT effectiveness, decrease AIT adverse events, extend AIT indications, and steroid sparing effect. AIT as well as the biologicals are synergistic as well as the additive effect. So friends, at present we have got a pharmacotherapy. Is there a remission? Hardly 9%, so that is so far in literature is natural remission. You give it continuously. But allergen immunotherapy, if you start in a stage of the pre-remodeling remission, is to the tune of more than 50%. We have got a very robust studies. We know the gap studies. given 3 years, 2 years, long-lasting effect. We have got a PAT studies given 3 years, 7 years, long-lasting effect. Biological, as per se now indicated in the severe asthma of step 5 of VINA guidelines. 50% reduction in exacerbation has been found by various studies, but the clinical remission is only 30%. Means in step 5 VINA guidelines, clinical remission is only 30%. But if we add biological in the state of the pre-mortem stage, like in intermittent asthma, then the clinical remissions will give up to 70%. Where is the evidence? Now let us see now. In respiratory allergy, this is the meta-analysis done. 11 RCT done on 901 patients, and they found that enhanced efficacy and safety in steroid sparing diet, improvement in the symptom scoring, improvement in the rescue medications, as well as significantly few episodes of the adverse event. Combining omalizumab allergen immunotherapy favors. Combining omalizumab allergen immunotherapy favor reduction in the symptom scoring, favor rescue medication score, has also increased in the quality of the life. One study came in 2022 that if first year if you give omalizumab and subsequently if you add AIT along with the omalizumab, there is no adverse effect even in a pediatric patient. Increase in the improvement or improvement in the FEV1 also, as well as the early achievement of the maintenance dose. Hardly few adverse events occurs during the 3 years course of the. Another study, omalizumab given along with the osteostomide found this is the only omalizumab and green one is the only subcutaneous immunotherapy. But if you combine, there is a marked reduction in the symptomatology and the medication scoring. Combine both. Guidelines of insect allergen immunotherapy, those who have got a recurrent anaphylaxis or those who have a history of the mastocytosis or other disorders. If you combine allergen immunotherapy with biological, adverse events are less and one can achieve the 100 microgram of venom immunotherapy. We have done case series combining with both, and we found that safe, effective, and gives more rapid relief of the symptoms. Reduction in the updosing. Usually, normally what happens, once you start allergen immunotherapy, updosing takes minimum 5 months. If you add omalizumab, that hardly 6 to 8 weeks you can achieve the MTT, the maximum tolerance dose. There is a decrease in the allergenicity, but maintaining the immunogenicity. In food allergy now recently a lot of the work is going on. Normally initially what we're doing at the Palforzia tablet for peanut came in USA, they started and most of these patients, they got adverse events during the build-up phase, abdominal pain and anaphylaxis. Then the further study found that if you give 4 months before the starting of the food allergens, then the tolerance occurs and there is a less adverse events during the build-up phase of the food allergens. Even the omalizumab facilitated multi-food OIT and we can achieve the tolerance up to 55% of the patients. Different foods has got a different IgE affinity. So there is a different tolerance occurs if you add with the omalizumab. So conclusion is clear that omalizumab enhances the safety of food immunotherapy, especially in patients those who have a history of the comorbidity. These are the meta-analysis done, and these are the doses which is variable of the omalizumab given in the various studies. This is a hot topic now today. Adding omalizumab with allergen or a food allergen immunity. Most of the studies in the literature are on omalizumab. but very few studies are there on the dupilumab as well as the tezepelumab. There is no study in the literature of anti-IL-5 or friends, we have got 5 biological available in the world. In India, we have got hardly 3. So our focus is now how these they work. IG, as per se, the biologicals are derived from the living organism. They are the high molecular weight component and they are often of a few amino acids. Some against the cytokines and some are against the receptors also. And some are against the monoclonal antibody. Now we talk of the omalizumab, the first fact record of more than 20 years. Omalizumab is an anti-IgE. IgE is a byproduct of the B lymphocytic activity which take permission from the T cell active once the dendritic cells present the antigen to the naive T cell to synthesize the Th2 lymphocytic. So if you look at the IgE antibodies, constants epsilon 2 and 3, this is the site where this binds to the receptors on the effector cells. Effector cells means mast cells, vesicle cells, eosinophil cells, airway smooth muscle cells, dendritic cells. If you block this site, constant epsilon 2 and 3 by the omalizumab anti-IgE, then this Ig antibodies will be unable to reach at the receptor. In the circulation, it will form primers and X. Once this forms, then there is a decrease in the density of the receptors at the effectors. Decreases the sensitization. At the same time, once the effector cell are the less IG receptors, then there will be no cross-linking, no degranulation. Also, it decreases the exacerbation. The second most important function of the omalizumab is that normally what happens, our dendritic cells, the most important cells, professional cells, they activate our naive T cells to synthesize the Tregs. But on exposures to the glycolipid, TLR, toll-like receptors 9, on activations they synthesize in the. But in case of the allergic patients, on exposure, once this dendritic cell is already loaded with the Ig receptors because of the high T2 inflammation, these dendritic cells are unable to synthesize. And if you give the omalizumab, where the trimers and hexmers are formed, then IgE receptors will be decreased and the normalization of the Tregs. This is the second function. Now look at the third function. This is the very recent function which has come. Only one study, the chalk study, is there, which says that the only study to demonstrate the reversibility of the remodeling. We were looking for the remodeling treatment, but this study has come now that it reduction in the intercellular spaces, decrease RBM thickness, decrease airway wall thickness and opacity, decrease fibronectin deposition. So we need more study on this to confirm this. So friends, omalizumab in immunotherapy, whether it is a respiratory or food allergy, reduction in the IgE axis, decrease cross-linking of the Ig receptors, increase in the IgG4 and IgE ratio, and decrease in the frequency and the expression of the ligand, the OX, T cell and CD. Now, other functions are there. Food allergy, nasal polyp, isolated. We are not giving you the iron therapy. But the second most important biological is a anti-IL-4RA. Now we are looking at the cytokines of the Th2. Th2 cytokines are IL-4, IL-5, and IL-13. Now, IL-4 and IL-13 are the important cytokines. And once we look at the IL-4 receptors, there are two types of the receptors. One receptor is there which sends the signaling effect to the JAK1. Another is there which sends the signaling effect to the JAK1 and 2. It is the JAK4 RA receptors which has got a twins with the IL-13 receptor. So if you hit these receptors, you are hitting also the IL-13. So this is first, that's why the word has been given to dupilumab. Means if you with one arrow you are killing the two birds. एक तीर से दो निशान. So dupilumab is the day that IL-13 is the only cytokines which is responsible for the ongoing remodeling at the level of the epithelium. We know at the level of the epithelial there is an intrinsic nitric oxidation power. Now, this once interfere with this, there is the excess formation of the nitric oxides, and we have got a high fever, fractionated expired nitric oxides. So, this epithelial level, and also at the level of the smooth muscle, IL-4 and 13. Otherwise, IL-4, we know it is for B cell lymphocytic activity as well as the Th2 lymphocytic activity. But these two are very important functions of IL-4 and 13. And if you give dupilumab, we can decrease this cycle. And the only diagnosis by whether our patients need dupilumab, IL-4 receptor alpha, high fever. The studies done also, they found that if you give Mipoli, IL-5 reduction was there, eosinophilic reduction was there, but there was no reduction in the genome. We need treatment of IL-4R, and now the recently work is going on whether the dupilumab is going to reduce the rebound. The study which has been done combined with the allergen immunotherapy is only in the atopic dermatitis. They found that allergen immunotherapy, dupilumab, the combination treatment improved clinical symptoms and quality of the life in AD patients. AIT promoted allergen-specific IgG4 production so that dupilumab reduced the allergen specific. This was the study they found that if you combine, the effect is much better than if you give separate allergen. So now coming to the biological, which is act on the eosinophilic differentiation, eosinophilic maturation, eosinophilic survival, and that is the IL-5. And we have got two biological, anti-IL-5, mepolizumab, and anti-IL-4 receptor, which is available in the name of the personnel. So these drugs are there. We know that if we indicate, function are different, but indications little bit are same, but only the EGPA function is different, which is indicated by the Noperi. Most of the studies has been done. Now, the Mipoli anti-IL-5 act as a competitive intervention on a free IL-5, while the anti-IL-5 RA receptors act at the receptors level by the mechanism of the ADC, antibody-dependent cell toxicity, got certain activate macrophages. That's why you use the term zero eosinophils with anti-IL-5 receptors and less eosinophil in case of the only the anti-IL. So these are the drugs. So it indicated in EGP also now, and it also is going to looking for whether it is also decreasing the area burden. Still, it is debatable. So the last is the tezepelumab. Tezepelumab is a epithelial-derived cytokine. We know whenever there is any environmental insult, the three cytokines IL-25, IL-33, and the TSLP is synthesized. The major source is epithelium, but TSLP is also synthesized by the various inflammatory cells. Now the studies are going on that if we hit this TSLP, irrespective of the whether the patient belongs to the high T2 inflammation or non-T2 or a low T2 inflammation, it is going to help in exacerbation. Studies are there and it is coming. Unfortunately, we don't have, but this is the only indications those patients who are having recurrent exacerbations, need of the OCS, AG is active. Again, whether this is going to help in remodeling, still we need use. One study is available that tezepelumab combined with allergen immunotherapy has a rapid reduction in the symptoms because some of the allergens they are likely to produce adverse events during the course of the allergen immunotherapy. And if you add this, then the adverse events become very less. So friends, these are the biologicals in indications. Questions arises, which patients do I give biological? Which biological do I give? In India, we have got a three. I just give you the one example. Now, this is a patient of the adult onset asthma, house dust mite allergy, eosinophilic, pneumonia is also high, fixed airway obstructions, comorbidities, AD and A. What will you do? We have given LAVA, LAMA, ICS, it's all the drugs that are available. We have tried, nothing happens. But this has a comorbidities of the AD. The drug of the choice is anti-IL-4 receptor. So whenever we plan for any selections of the biological, we must think whether my patient is on LAVA-LAMA ICS. Then we ask the patients whether he is steroid dependent or whether he is a non-steroid. If my patient is a non-steroid dependent, then we ask what is the number of the eosinophils. If it is a less than 150, we ask how many number of the exacerbation. Drug of the choice is omega. And if the eosinophils of 1 in 50, then again two questions asked. Whether how many are type, how many number of exacerbation and symptomatology of the patients. And then we go for the FEV, non-function. If FEV1 is more than 70, exacerbations are less. Patient has a comorbidity, the urticaria, food allergy. Still the choice is of convention. But if the FEV1 is less than 70%, then the choice is of M for mepolizumab, B for benzalazumab, and D for TEGI is there, but TEGI we are not discussing. It has not been indicated. Second point is there that if symptoms are more and FE1 is more than 70, then we must think of coma, which is the predominant primary coma. This is nasal polyp, then dupli, mepoly, and omeli. If it is atopic dermatitis, dupli, urticaria, omeli, and otherwise if it is a EE, then again the omeli. Otherwise, we can think of the pheno also. If pheno is on the higher side, then the choice is with the anti-IL-4 dupli, omeli. But if pheno is a normal, then we point it only towards the anti-IgE and anti-TSA. But if there is no any sensitization, nothing FE1 or other parameters, irrespective of that, the drug of the choice, that's only for exacerbation. This is a systemic review which has been given already, but one should be very specific. If the eosinophil count is more than 1500, now the drug of the choice is being kept. Whether Bendali is there, still we are looking for more study. Why some patients they don't respond to the biology? It's not a magic bullet that everything will be okay. Because once the patient in a state of a severe asthma or a persistent asthma, remodeling is there. You can't reverse back the remodeling. And some of the remodeling parameters are reversible or are not reversible. So not only this, we are giving some biologic, some antibody, anti-antibody. of medications related. It is found in some of the patients, they produce anti-drug dependent antibody called ADA. And some of these patients, they have got also the disease related. If it is a disease related, means many comorbid diseases are there. The phenotypic selection or the endotypic differentiation, we must do it, but still we fail because it's low T2 and high T2. Not only it could be mixed also. It is the choice, the selection must be done, and it depends on which high T2 or the other disease is there, which is not practical where this biological effect. And the third is there that we should consider the patient related factor. And most important is the comorbidity. We have to control the comorbidity. If we are unable to control, because some of them they have got a food allergy and anaphylaxis. So what will you do in these cases? You combine two biological reasons. Even we have tried also. We patients of allergic asthma, atopic dermatitis, CSU, spontaneous urticaria, we are giving two words, but very few are there. But most of these patients have got eosinophilic, allergic, along with that other comorbidities. So two metabolic as well as the biliary. Now these are the combinations which has been given, but now Dr. Rakesh has very well mentioned on the autoimmunity also. In autoimmune, we get cases of asthma with ankylosing spondylitis. Combination is also synergistic. One of my patients, he is on a secukinone and with omalizumab or adalimumab, adali is there. So both are synergistic. So friends, improve control of allergic symptoms, enhance tolerance and effectiveness, reduction in the need of the symptoms relief medication, improve quality of the life, and the most important is modifying. Short-term efficacy is there in the literature, but we are looking for the long term. So outlook better, and thank you very much for it.
Thank you, Dr. Kathuria sir, for the wonderful presentation on biologicals in immunotherapy. Your session was full of valuable take-home points. So today's session reminded us that the pediatric immunology is rarely black and white. Allergy can masquerade as immunodeficiency, recurrent infection, demand careful immunology reasoning, autoimmunity overlaps with allergy, and the new biologicals are rewriting how we can treat these children. Together, these talks highlighted that clinical immunology in pediatrics is about pattern recognition, precision, and above all, personalized care. Thank you once again to all our speakers and the audience for an engaging session. Now I hand over proceedings to Dr. Neeraj Gupta to conclude this session.
Thank you, Dr. Vipul sir. I think once again an excellent session, excellent webinar, and I must thank all the speakers for their wonderful deliberations, Dr. Payal, Dr. Neeta, Dr. Rakesh, and then Dr. Kathuria sir, especially the clinical touch which Dr. Kathuria has given about the biologics and the how, when, what to use and what to choose. So which is always, you can say, like a difficult area, but with so many years of experience, I will say decades of experience, he has made it so easy to look for, but definitely clinically it is actually challenging. So thank you very much, Dr. Kathuria sir and everybody, and thank you, Dr. Vipul, for moderating this very nice session. And with this, now we will come to the end of this applied immunology webinar series, the 3 episodes, and now we will move to our national annual conference, which is PedAlerCon at Delhi. So we all will come together, gather together on 10th October at Taj Vivanta, Dwarka. Until then, please enjoy, stay healthy. Thank you. Good night. Thank you.
Good night. Good night, sir. Thank you.
Night, doctor.